Vice Chairs of the National Advisory Committee for Neurological Conditions. It's a great pleasure to welcome everybody along today to our network launch event. So this is the first meeting of the Neurological Conditions Network entitled Connecting Care. We want to use this session to achieve a number of goals, really. One is to start to hear about some of the innovative approaches to delivering services throughout Scotland, and learning a little bit about the impact on people who have benefited from these approaches. We want to create an opportunity for you to meet with colleagues across Scotland, and we want to Is that coming from me? Right. Is everybody else hearing? That echo? Yeah.
Yeah.
Is it me, you, and
I think somebody will need to mute their mics. It's probably a conflict, Jenny.
Yeah.
If we all mute our mics, it'll be better.
Can we just ask somebody to mute their mics, please? One of me is more than enough, let me tell you. Okay, that sounds better. Okay, so we want to create this opportunity to hear about innovative practices that are taking place. We want to create an opportunity for you to meet colleagues. We want to demonstrate a commitment to working collaboratively, and it's great to have people representing a range of sectors today. And we want to involve you in influencing the network program going forward. Sorry, can I just check that everybody's muted, please? Included within this session are people from a range, from all the NHS boards, I believe, and we've got a range of third sector representation joining us as well, which is fabulous. So in order to help us to get a better understanding of who's all involved this morning, we'd like to do a quick interactive poll, okay, to get a sense of where everyone is from, and also to gauge expectations of this session. So Susan is going to put two quick polls into the chat. So if you could engage with that, that would be incredibly helpful. Thank you. Okay, Susan, if you can just give me the nod when.
No problem. We seem to be getting a lot of responses, so I'll give it a few more moments.
Fabulous. In the meantime, I should actually say that we are recording this session today so that it can be shared with people who are not able to join us. So if anybody does have any objections to being recorded, could you please let Ewan know? That would be really helpful. Thank you.
Paula, I'm really sorry that the links are not working. If you could just pop the answer into the chat, I will let you know what the actual question was. It was, what were your expectations of attending today's session? And there was a number of different options. I'll actually present them on the screen just now so that you can see just very briefly how some of these answers have been in. Share my screen. Now this will continue to be updated as people further respond, but just to give you a bit of a brief overview, that's certainly how the initial responses seem to be coming in. So it's nice to see that people are looking for a networking opportunity and some practice sharing.
Okay, great stuff. Thank you. Thank you. So we're kicking off this event by showcasing the Right Decisions service, which many of you may already be familiar with, and is an established platform to support positive changes to delivery of health and social care services. Connecting across care settings is a theme that came out strongly from the self-evaluations of the General Standards for Neurological Care and Support undertaken in 2023 to 2024. And the Right Decisions service is a good example of this. This presentation will be led by Dr. Anne Wales, Programme Lead, Knowledge and Decision Support, Healthcare Improvement Scotland. Susan Dillon, who is supporting and technology this morning, and is one of our network coordinators, will also talk about her experience of developing resources on the platform, and we will hear from a service user on the benefits to care that this has brought about for them. We also want to use this session to launch and to shape our national and regional improvement networks. So today we will be seeking your help to define the common purpose for the network, and through your feedback today, start to define a structure and governance model. Due to Scottish Government financial constraints, however, it means that we are going to have to move forward with the network on a considerably reduced resource. We do not have the funding to continue to support the network coordinators, excuse me, after December. So we will need to think about how we manage and coordinate the networks in their absence. We would also like to acknowledge the impact of all resource challenges on all organisations and services, and that a focus on improvement can be particularly challenging, but this is about using the resources that we do have more effectively. Through the networks, we want to deliver improvements in services through collaborative working. Susan, do we have an update on the poll?
I'll just double check and see if we've got any further answers. They're still looking very much like a similar spread, excuse me, across networking and practice sharing, with between 25 and 35% interested in the self-evaluation feedback and right decisions information.
Okay. Thank you. So, not getting off to the best start. I'm already late, behind schedule. The aim is that we do try to keep everybody on time today, because there's a lot to get through, and we do want to hear from as many people as possible. So, without further ado, I'm going to pass over to Richard, who'll give you a quick recap of the story so far. Richard, thank you.
Thanks, Jenny. So, yeah, I'm Richard Brewster, and I work in the Neurological Conditions Policy team at Scottish Government. And this is a whistle-stop tour through the strategic backdrop to this session. So, Neurological Care and Support in Scotland, the Framework for Action 2020 to 2025 was launched at the end of 2019. Has a broad vision that everyone with a neurological condition will be able to access the care and support they need to live well on their own terms. And you can see on the graphic here that under that vision, there are 5 very broad aims, and under those 5 broad aims, there are 17 more specific commitments. So the delivery of that's coordinated by the Neuro team at Scottish Government. The strategy is shaped and advised by a National Advisory Committee for Neurological Conditions, drawing on expertise, cross-sectoral and cross-professional expertise from across Scotland. And we report to the Minister for Public Health, Women's Health and Sport, Jenny Minto, MSP. When the framework was launched, that was accompanied by an investment of £4.5 million over 5 years. So moving on to the next slide, please, Susan. We just this broadly summarises some of the things we've done under each of those 5 aims. I'm not going to talk in detail about that, it would just take too much time, but I want to summarise 3 key points in relation to this slide. Firstly, to note that we funded 41 projects that deliver innovative or new ways of delivering services. And I've included a link to where you can find out more about those projects later in the slide set. The second key point is that we rely very heavily on partners in delivering and implementing the framework. So, for example, under AIM-D, our colleagues from the Centre for Sustainable Delivery in partnership with clinical colleagues have developed a range of care pathways, patient-initiated review, condition-specific pathways equally. The Neurological Alliance of Scotland support us. They've developed a number of resources, for example, for carers and self-directed support, and also help us with engaging with people with lived experience. So it's really important to acknowledge those elements of the framework. And NHS Inform is also a really important part of what we've done, and we've got 23 revised or new pages on neurological conditions over the period of the framework. The third point I would like to emphasise is the self-evaluation of the general standards for neurological care and support, which many of you were heavily involved in earlier this year. That's set out improvement objectives, improvement plans for all of the NHS boards and health and social care partnerships. And that's what we want to build on through these networks. We want to help to support the delivery of those improvement objectives and shape collaboration going forward. So moving on to the next slide. Very quickly want to highlight this slide from the Health Foundation. And these are sort of key success factors of healthcare networks. So in the centre, in the nucleus of this diagram, you've got common purpose. And that's what we want to try and determine today. Cooperative structures is another key factor. And then around the outside, you've got these sustainability factors, critical mass, community building, and collective intelligence. So I think it's just important to sort of flag that up in terms of how we want these networks to be shaped. And so moving on to the next slide. Thanks, Susan. Here's a list of contacts, key resources that we have developed across the scope of the framework. One of the things that came out strongly from the self-evaluation was the idea of better coordinating and linking services up. And that is one of the reasons we've invited Anne Wales to come along and talk about the Right Decisions Service, because we feel that that offers potential solutions to that particular area of identified improvement. So that is all I'm going to say in terms of that scene setting. And I will pass on to Anne to talk about the Right Decisions Service. Thanks.
Okay, thank you very much indeed, Richard. So for any of you who don't know me, I'm Anne Wales. I'm the Programme Lead for Knowledge and Decision Support based in Healthcare Improvement Scotland, and I manage the National Decision Support Programme for Health and Social Care. At the heart of that is the Right Decision Service, our national decision support platform. And I'm really pleased to have the opportunity to discuss with you today how the Right Decision Service, RDS for short, can support this Neurological Conditions Network. Really look forward to the discussions and to hearing your ideas and hopefully moving them forward with you. So the backdrop, as I think has been indicated in the introductory sessions, the backdrop to the interest widely in the Right Decision Service just now is the urgent need to deliver value-based health and care. I've got a few quotes here from the Realistic Medicine website on value-based health and care, and I'm sure you'll all be familiar with some of these figures. So hugely increasing demand for healthcare. Approximately 10% of that is due to the ageing population, but the great majority is apparently clinician-led. And we therefore really need to support clinicians to make decisions that tackle unwarranted variation in practice that can result in overuse or ineffective use of tests and interventions. A link to that is the estimate that's quoted by Realistic Medicine from the OECD, that up to 35% of this increase in activity is likely to be low-value treatment and care or waste. So an urgent need to really shift our decision-making collectively to be more strongly based on evidence and addressing unwarranted variation and harm. Now, there are plenty of guidelines available. There's a continuous pipeline of guideline development and updating, both nationally and locally. What we're talking about here is not only the production of guidelines, but the implementation challenge, getting those guidelines into practice. Some of you, I'm sure, will be aware of the evidence showing that there's often a gap of between 5 and 17 years between publishing evidence, robust evidence, and it getting into routine practice. One of the main reasons for that is that our traditional methods of disseminating research and guidance are limited in their effectiveness. So if we look at this sort of simple data to knowledge to practice flow, you can see intensive work going on around research and analysis to create knowledge products such as research articles and guidelines and pathways. But our traditional methods of disseminating these through PDFs, for example, do have limited impact on practice, and that's well documented. What's also well documented is that different types of digital decision support can be much more effective in accelerating that translation of knowledge into improved practice. And that's really because of the power of digital to integrate with clinical workflow and day-to-day behaviours of both professionals and citizens. So the Right Decision Service is really a national commitment to delivering a Once for Scotland approach that brings the evidence right to the hands of practitioners and citizens through everyday technology that can embed this validated evidence in a day-to-day work and practice. It's designed to enable people to make safe and personalised decisions quickly on the go, but with the confidence that those decisions are based on validated evidence. And the intention is that should flow back to addressing some of the variation in practice by making it much quicker and easier for everybody to do the right thing at the right time. The Right Decision Service supports quite a spectrum of types of decision support. At one level, it can be seen as a repository for evidence-based guidelines and pathways, but our real unique selling point for the Right Decision Service is going beyond being a repository to format and organise the knowledge in these guidelines and pathways in a decision-ready format that makes it much quicker and easier for busy clinicians and patients in the public to quickly get the information that they need. And we use the power of digital-first approaches to achieve that decision-ready digital formatting. However, even that type of computerized knowledge, where it's presented in much more action-focused, decision-ready structures, is still human-readable knowledge. We know from the evidence that the greatest impact of decision support will often come when the decision support is embedded in electronic health and care systems, and it goes beyond just being readable documents to actually use the power of knowledge-based algorithms. I'm not talking about machine learning here, knowledge-based algorithms to process patient data and push out evidence-based recommendations for practice based on the specific characteristics of the patient. So the Right Decision Service does support this full spectrum of decision support, and we're constantly driving to maximise impact by moving towards point of care, computerised knowledge, and embedding the knowledge in systems. From a practical point of view, most of you will encounter the Right Decision Service through the Once for Scotland website, the Right Decisions website, or its companion, the Right Decision Service mobile app, which can be downloaded from the app stores. We have now over 180 individual decision support toolkits, all accessible through both the web and the downloadable mobile app. However, as I said, we are moving beyond simply providing this web and mobile content through a website and app, and beginning more and more to actually embed decision support in electronic health record systems. This is an example here of where the Right Decision Service has been used to create decision support algorithms based on national guidance, and to use those algorithms to interact with individual patient data from, in this case, the Vision Primary Care Electronic Health Record System. When the clinician opens an individual patient record, the Right Decision Service pushes out alerts about any high-risk prescribing issues for that patient based on the national guidance. The clinician can open up each alert, see the nature of the risk, and see a recommendation for action. But just to illustrate a bit more the variety of types of decision support that might be of particular interest to this group, I have just taken a few screenshots to share with you. So the Right Decision Service is used very much as a means of delivering national guidelines in decision-ready format. We now work really closely with SIGN to ensure that all their new guidelines are delivered through the Right Decision Service as the primary channel for dissemination of those guidelines. This is one example, the pharmacological management of migraine. You can see all the content from that a PDF document is chunked up for easy access so the clinician can quickly go into the section of interest. If they chose, for example, preventive therapy, you would see key calls to action at the top of the page, and then the clinician could just go to whichever particular section is of most interest. For example, first-line therapies, open that up, see the recommendations with the little R beside them, or the green tick for a good practice point. So very user-friendly, quick and easy to navigate. Richard, I think, mentioned the Centre for Sustainable Delivery, who deliver their neurology pathways through the Right Decision Service. This is an example here of the functional neurological disorder pathway. The clinician will see a set of collapsed headings, and can quickly jump into, in this case, the pathway recommendations, which are nicely presented both visually and in short text format. And this is just to illustrate the fact sheets for GPs that are on the same toolkit. These can be accessed in simple PDF form currently, though we are looking at translating those into a fully digitised web format as well. But it's not just national content that's available through the Right Decision service. It's used by regional networks and by individual territorial boards and HSCPs as well. So here on the left, just as an example, I have the spinal pathway from NHS Dumfries and Galloway's primary care referral guidelines, and on the right from NHS Highland, their guideline around Guillain-Barré syndrome. Hopefully you'll be kind of familiar now with the structure here, the collapsible headings that allow the user to quickly get to the piece of information of interest. Another way of presenting the information concisely and make it easy to navigate is in the form of visual pathways. These are all fully embedded in the web and mobile app. The user can pinch and zoom to move about the pathway, focus on the node of interest. The nodes can be colour-coded to indicate risk level, and you can associate any node in the pathway with a little information icon that will open up a side panel. You can see over on the right here an example that just expands on the information in the node and can provide links to related guidance, patient information, etc. Patient and public resources. So I said in our mission statement that the Right Decision service is both for professionals and for citizens. This is an example of the Greater Glasgow and Clyde Dissociative Seizures app. I'm just showing you the mobile format here rather than the web format so that you get the picture. All this content is available through both routes. This is a really nice public-facing app. You can't see it in the static image, but these are, it's got a whole series of very engaging little animations to help bring the explanations and advice to life for the person. Here are just some of the design principles that we use to make the knowledge decision ready, clear calls to action, so concise text, lots of white space. We could do better there with some of these resources, but that's the principle we try and work to. Segmenting the information for speed of access, and this progressive reveal, as it's called. So having your key calls to action up front, and then you can link beyond that, deeper down to deeper levels of supporting information. And the overarching principle is the Once for Scotland single point of access, so everybody knows where to go to get their guidance and decision support. So far, I've shown you human readable resources, basically text-based and media-based. I'll move on now to just show you a couple of examples of where there are some algorithms working behind the scenes to process information. This can be really simple. I've got a screenshot here of a simple question and answer algorithm for assessing risk level in transient loss of consciousness. This is from the Forth Valley, a toolkit that is used by call handlers in their flow navigation hub, where they accept emergency calls about emergency referrals and decide on the appropriate routing for the patient. You can see here it's a simple set of checkboxes for high, intermediate and low risk factors. Depending on which item or a selection of items the clinician chooses, that will trigger either a recommendation for routing or another question. In this case, it's about the ability of the patient to attend the rapid access unit when they've got an intermediate risk level. If the answer to that is no, the emergency call handler is advised to do an inpatient admission to the clinical assessment unit. Yes, is that 5 minutes?
It is, I'm sorry, thank you.
Thank you. Thanks for the reminder. This is really simple, just to give you the basics of the word algorithm can be a bit off-putting, but it can be as simple as a few questions and recommendations like this. The user can save a PDF record of the whole decision pathway and their responses at each point in the question and answer sequence. We can take that further to create a slightly more complex risk assessment and scoring tools, where the answers the user gives will be associated with an algorithm that calculates a risk score for the patient. So this is the NEWS2 calculator that we've developed, linked with the SIGN guideline around care of deteriorating patients. You can see the clinician enters the physiological parameters and a risk score is issued along with guidance that corresponds to the SIGN guideline. And we have and do develop significantly more complex calculators than that if required. So just another example, the 4AT tool embedded in the delirium risk reduction guideline, a very nice, very usable way of assessing risk of delirium and getting a score with recommendations for action. Very simple, but we've had really good feedback on it improving consistency in practice. And finally, that interactive approach can be extended to patient and public resources as well. One of the points that was made by the introductory speakers was about the importance of shared decision making. An example here would be the Wellbeing Diary that's part of our dementia Living Well with Dementia app for people living with the early stages of dementia and their carers. This just allows people to make a very simple choice of answers to a series of 5 questions about different wellbeing outcomes. Based on their answers, there's a little report generated showing how their wellbeing outcomes improve or deteriorate over time, and they can share that with their care professional to support shared decision making. We're currently in discussion with one of the teams in one of the health boards, but using a similar approach for a headache symptom diary that would support decision making about treatment by clinicians. I've given you a number of examples now of existing web and mobile apps. I want to stress these are developed as a service by the Right Decision team, working with national, regional and local teams. We don't own any of this content. It's all owned by the providers themselves, and our role is to support you in getting your content available through the platform and as user-friendly and decision-ready as possible. So I would really encourage everyone within the network to please get in touch if there's tools you would like to create locally or regionally using the Right Decision service, and we can talk you through the process and the governance around that. Just to sum up, I started talking about value-based health and care. I hope the examples I've showed illustrate the ways in which the Right Decision service can support value-based health and care by helping to reduce harm and unwarranted variation, supporting shared decision-making, care that's based on individual patient needs. Got a very good body of evidence about the amount of time the Right Decision service saves for busy clinicians finding guidance. And it's absolutely about making best use of available resource. This is a resource already available to everybody across health and social care. And in these challenging times, it's especially important to make best use of that. And we're keen to help you to do so. Thank you very much for your time. I know Susan's got some more examples to share with you, but I hope I can stay on to answer questions as well. Thank you.
Thank you, Anne. I will just very quickly share my screen. So yes, thank you, Anne, for that very interesting presentation. For those of you I haven't met previously, my name is Susan Dillon, and I'm one of the regional network coordinators. Prior to taking on this role with the Scottish Government, I was in post as Neurology Framework Project Manager within NHS Greater Glasgow and Clyde, where I was working on a variety of funded projects, including the development of toolkits for the Right Decision platform. And as Anne has already shared, for those of you who aren't familiar with the platform, there is a link to the website and there is an app available for download. I would encourage everyone to either access the platform online or download the app so that you can review the toolkits at your own pace and you'll be able to share within your own services and colleagues who are not attending today's session. As Anne has already said, there is a wide variety of toolkits available on the app for you to review. And once you share these with your wider teams, you can see how this platform could work for your service and look at some of the specific functionalities. Now, toolkits can be reviewed in a variety of ways. They're simply organised by A to Z, by organisations, etc. So at present, NHS Greater Glasgow and Clyde are continuing with the work on developing toolkits for epilepsy, headache and motor neuron disease. There is also a spinal injuries toolkit which is in development, and there is a toolkit available for you to access on deep brain stimulation, where you'll be able to review just some of the functionalities that are available. This slide gives a very brief overview of the deep brain stimulation service, which is based in Glasgow. This is for people who have been referred to or are considering DBS as a treatment for their condition. And as you can see, there are tiles available for urgent care and advice, and there's also one for referrals where there is actually a link to the referral form. But there is a wealth of information within this toolkit, and it just illustrates how much information can be included and is accessed easily by service users with the information all in one place. This toolkit contains a patient information video and a patient journey video, which are available in the What is Deep Brain Stimulation. I would encourage you all to view these. I wish I had time to share them with you today, but they are quite extensive and I know that we've got a lot to cram into our session. But as I say, I would encourage you to all go and have a look at these. Back in January 2023, we were granted approval to progress the development of individual toolkits. The overall aim was to better support primary care practitioners, patients and carers to live well in the community by providing necessary information, guidance, referral criteria and signposting to enable self and community-based management of neurological conditions where clinically appropriate. Once we started to look at the services and the toolkits that we wish to prioritise, overwhelmingly, we found that our main focus, along with the aims of this piece of work, were to ensure a person-centred approach. Families who were supporting a family member with a diagnosis of a neurological condition, who often felt very lost in a wilderness of Google searches, could have reliable and validated information available to them, their families and their carers at a time of their choosing and at their fingertips. It became essential for us to put patients and families at the heart of this process. For toolkit development, it is essential to consider where to start. However, I appreciate this can feel very overwhelming when you have to consider everything that should be included. But it is essential to simply just consider what information should be shared and how best this can be shared on the platform. For example, a variety of toolkits use videos that were already in existence on the NHS Greater Glasgow and Clyde YouTube channel. It can provide links to local information. As Anne has already said, we can embed forms and questionnaires which can be completed by patients or healthcare professionals. And it can also include links to PDF versions of patient information resources. It is incredibly important to note that much of this information was already available to some patients, but in a wide variety of different places and in different formats. For example, in developing toolkits for the epilepsy and the motor neuron disease, we were able to utilise a lot of information from the NHS Inform platform, which had recently been updated by the clinicians. Developing the toolkit enables services to bring all of that information together in one place. A one-stop shop, essentially, with a host of information which can include advice on symptom management, everyday support information, help with common issues, and links to support groups and charities. As Anne has said, as well as providing verified information for patients and carers, the toolkits can also provide information on referral guidelines and further information for GPs and other healthcare professionals to help them identify the most appropriate care pathways for patients. As the range of neurological conditions and the number of care and support services are incredibly diverse, much of the information in toolkits can be replicated across conditions. With collaborative working with patient forums, third sector organisations and other support organisations, signposting becomes incredibly easy. But it is essential to note that the RDS teams do take the responsibility for the technical programming of each toolkit. So any service wishing to develop one will have the full support of the RDS team and will be guided through the process, as Anne said. And I can personally vouch for the team for being incredibly helpful and always supportive in the development of the toolkits that I've worked on thus far. When developing the toolkits, we used a variety of methods to communicate with our teams. We created a Teams channel so that everybody from clinicians and clinical nurse specialists to pharmacy colleagues, so they could review the data that we were uploading at a time that was suitable to them, gathering the information for a variety of sources, including existing YouTube videos, which could enhance the toolkits, and also with the help of the medical illustration teams to consider new videos that could be produced, such as wayfinding, introducing teams, or demystifying some of those more complicated medical procedures. We held regular meetings with the RDS team, and it helped not only enable the governance and testing by team members, but perhaps most importantly, considering our patient and carer users. Whilst with best intentions, we can anticipate what information should be shared with service users. This service user testing really opened up our eyes and identified potential gaps in the information provided. For example, in the development of one toolkit, service users identified a number of things that we had not included, such as relationship advice, neuropsychology, benefits advice, and palliative care. At the risk of repeating myself again, I would strongly recommend having a look at the platform at present. You'll see the following toolkits under Neurology, However, I anticipate this to be updated as the toolkits that we've previously mentioned are continued to work on and are tested with the team that are working on them at the present. NHS Greater Glasgow and Clyde are also working with members of the public to help the Right Decisions app. This is to ensure it meets the needs of the people who use it. There are several focus groups taking place in November, and people who use services or are interested in helping are encouraged to contact the team. I do have a link to the MS form that's available, and I will share that in the chat function. I appreciate that was a very whistle-stop tour on how we'd progressed with this, but hopefully you've got some time for some questions and answers. I'm sure you'll have lots of questions for Anne.
Thank you, Anne and Susan. Incredibly helpful, and certainly something that I think we would all be keen to explore a little bit further. So Susan, thank you. And Anne for keeping us on time. So we now have some space for questions. So I'd like to open that out to the floor. Does anybody have a question? Glasses on. Okay, right. Crippen, do you want to come first, please?
Thank you very much. I think that's really interesting and lots of information. I'm sure I'll absorb it after the meeting as well. But just one question is, what will be the criteria for getting a specific toolkit up there, or how does who decides what toolkits are progressed?
So yes, the decision about what toolkits are to be uploaded to the Right Decision service primarily sits with your own organisations. So if your organisation, whether it's local or national or your regional network, has got validated good quality guidance in place and it wishes to use the Right Decision service to provide access to that guidance, we will support you with that. Our toolkit request form, it's actually a set of 3 forms that guide you through the process. But the very first toolkit request form asks about the purpose, the context, the audience, the benefits to health and care, and most importantly, where does the governance approval come from within your organisation, so that we know the content is all well governed and validated. During the course of development of your toolkit, we require that content maintenance and updating processes are documented so that we know that anything on the Right Decision service will be kept up to date. And then finally, before we press the button to go live with your toolkit, there's a set of quality assurance criteria. So that includes things like, has a risk assessment been done, to see if there's any possible risk of people not seeing the right guidance, for example, when they come to the relevant page. Has user testing been done? Can you confirm that the most up-to-date evidence has been used to inform the guidance, etc.? There's about 10 criteria. And where your guidance references medicines guidance, we require that within local boards, the ADTC has approved that guidance before we'll publish it on the Right Decision service. So essentially, the Right Decision service is a hosting and support, a hosting platform and support service. The ownership, responsibility and governance around the resources sits in your organisation. Our governance is checking that your governance is actually in place and meets our quality criteria. I hope that helps. Probably too long-winded.
No, that's perfect. Thank you.
Thank you. Ian, do come in.
Thank you. Yeah, it's really interesting, both Anne and Susan. Obviously, anything which provides good quality, easy to access information to patients and health and social care professionals is most welcome. Just a couple of questions, not necessarily MS specific. First question is really how patients will be signposted to the patient's side of the app. How are they going to be signposted to access information there? And secondly, just in terms of the pathway development that's been published on the health and social care side, will that as a standard include signposting to other sources of support, such as third sector organisations, or will it just remain as internal NHS?
Well, to take your second question first, it's absolutely the case that many of our resources do signpost to third sector organisations. They're vital partners in care, so there's no restriction that it's purely NHS information that's signposted. In terms of the patient and public access, Susan can maybe speak about the Glasgow experience, but the core kind of principle that we work on with the Right Decision Service is that health and care services and professionals, they will signpost the person to the resource as part of the care process. So that can be through a QR code, or it can be through emailing a URL, but we don't generally assume that patients themselves will find the Right Decision Service and use it to explore what particular resources are available to them. It's much more a partnership approach that professionals will make the patients aware. Here's a helpful resource that's really aligned with the care pathway that we're working with you on. Here's resources that can help you to self-manage, take part in decisions, etc. So it's very much a kind of a mediated approach, if you like, with the professional signposting and sometimes supporting the person to access the content. That's not to say that patients can't just find the resources themselves. They could, but our kind of core principle is more that this is a collaborative approach between professional and patient. I hope that makes sense.
Thank you.
It does, yes, thank you.
Susan, do you want to add anything about how you engaged?
Yes, we discussed this quite extensively of how we can get that information out there, because if we have all of this wealth of information, there's no point in us being very precious and holding on to it, and patients actually desperately needing that information and resources, and more importantly, so they can then share it with their families and their carers. We all know that you get given a patient information leaflet, and with the best will in the world, it will get lost in a car or it'll end up somewhere. And I come from a very large family, so it would probably be very dog-eared by the time it was passed round all of us. We looked at a variety of ways, and as Anne had said, QR codes, but very much signposting, not just at the point of initial diagnosis, but repeated signposting when patients come in, because we know people won't remember things. People will forget. They'll say, oh, I didn't access that. And we're very aware that not everybody has a mobile phone, not everybody has an iPad. But certainly in the case of my 96-year-old grandfather, he has 21 very active grandchildren that do, and we would all access that, and we can then share it amongst ourselves. It's the ease of sharing it that becomes the momentum, Ian. And I think really once word gets out and it's shared with your clinical nurse specialists and it's there shared in the community, it then does kind of gather that momentum, and people then start to access it as a matter of course. But it can also be put up on posters in clinical areas. It can be shared with people via email as well, and I really think it's an invaluable service.
Thanks. Yeah, I agree. And I think there's a real opportunity for charities like Revive MS Support and everybody else who's in the meeting today to support that and to make sure that our clients are accessing that level of information. Thanks.
Thank you. Thank you. Janet, what would you like to ask? Oh, I think you're on mute.
Sorry. Claire White's just asked a similar question in the chat, actually, which is a sort of basic thing for me is the talks all sounded like this is regional services being developed, and I just wondered if there was if there's a national guideline, if that's being could be rolled out nationally across all the boards, or are all the boards producing individual toolkits potentially on the same illness?
No, the first couple of examples that I showed were national. So the SIGN guidelines and the national pathways from the Centre for Sustainable Delivery. So yes, a lot of our content is national in nature. We support both the national delivery and the local delivery as well.
So who initiates the national guidelines then?
Yeah, the owners, the responsible bodies. So in the case of SIGN, it's the SIGN team within HIS. In the case of the Modernising Patient Pathways programme, it's that those programme leads within the Centre for Sustainable Delivery. So it's the same principle as local. It's whichever body and governance arrangements made that decision that they would like to use the Right Decision service.
Okay, thank you.
Okay, thank you. We've got a couple of minutes. We've made up some time, so we do have a couple of minutes. Are there any other questions? Leslie, do come in.
Thanks, Jenny. I think this sounds like a really good development, Anne and Susan. I think this is going to lead to better things. I guess my question in terms of patient facing, would that be NHS Inform? Because that's more accessible for Joe public rather than staff, because that gives advice on how to treat illnesses, whereas this seems to be more clinician and social worker and social care focused. I don't know what your thoughts are on that.
So one of the great examples that Susan showed, and also a couple of the ones I showed about supporting people with early stage dementia and supporting people with dissociative seizures, these are aimed at the general public, citizens and patients. We do work very closely with the NHS Inform and recognise the kind of complementary strengths of the two platforms. So NHS Inform is a national, public-facing health information platform, as you know. Where the Right Decision service comes in is in supporting that collaborative shared decision making between the person and the healthcare professional. So shared decision making tools like the Wellbeing Diary for dementia, for example, and we have a number of other examples like that. Also, what the Right Decision service does is support that local information. The examples that Susan has shared are from Greater Glasgow and Clyde, and we have a number of other boards, Borders, for example, Forth Valley, also using the Right Decision service for local patient information that would be out with the scope of NHS Inform. So the focus on the mediated access through health and care professionals, a number of the interactive aspects like the Wellbeing Diary and other algorithmic decision support, and the focus on localised, or the ability to deliver localised content to the public, make it complementary really to what NHS Inform offers. Having said that, virtually every resource we have for patients will signpost, the relevant resource on NHS Inform.
That's great, thank you.
Thank you. Okay, it looks like there's no more questions, so I'm going to move to the next part of the agenda. Oh, sorry, there is still one hand up. Richard, I do beg your pardon, do come in.
Yeah, sorry, Jenny, my camera's off just because of some of the reception problems that there were earlier, but somebody's put a question in the chat around. So Susan Robertson has said, what's the time frame for setting up the platform in relation to bespoke to particular service? So I'm not sure I can answer that in the chat, and I just wonder if maybe Susan, you've got ideas on that.
I think it really would depend on the functionalities that you're looking to build into this specific toolkit, and the information that you were looking to build. It's kind of, I can't really give you a very clear answer on that, but I'm sure Anne will be able to give you a bit more information that once you're looking to set up your toolkit and you're filling in the paperwork and you're having these discussions with the RDS teams, they would be able to guide you on that.
Yes. So Susan's absolutely right. It varies quite widely depending on the volume of content, the complexity of the content. If there's lots of tables, lots of media that needs to be translated into the RDS, lots of visual pathways, these things will take more time than a straightforward text-based resource. If you want some of the interactive functionality, like the question and answer tools and scoring tools, again, that's more complex, so adds time. So the total time for delivering the content and getting it signed off can vary from 3 weeks to 9 months. It depends, very much on the nature of the content. Also, it does depend, because it's a partnership approach, it does depend on responsiveness from the content provider, who we rely on to do the user testing, to do the sign-off, etc. So it's the time frame is determined not just by our team, but the partner as well. One of the first things we always do at initiation is work with the partner to put together a project plan based on kind of the six key stages in the process, and then we keep that up to date.
Thank you, Anne. Fiona, one quick question, if you don't mind.
Yeah, quick question. Fiona Huffer from NHS Lothian, and we have a website called RefHelp, which is clinical guidance for professional people, not really encouraged for patients. Has there been collaboration between the two?
We had some discussions with the RefHelp lead over a year ago, maybe 18 months ago. They certainly were interested in exploring the possibility of using the Right Decision service. At that time, they decided to continue with their existing platform because they had a number of development plans already underway for it. But it is something I would be keen and to explore further with them, especially as NHS Lothian is now moving more and more on the acute side to use the Right Decision service. Oh, I think you're still on mute.
I was just thinking that's good, because it could be confusing if clinicians go in and use one Right Decisions and then are thinking RefHelp, but they both need to be collaborating to be sure that we use the right health board's Right Decisions information, because I've had people saying, well, this is what we can do in Glasgow, but that's not what's been agreed in Lothian.
Yes, that's right. And I see there's a reference just come into the chat about Dumfries and Galloway's RefHelp, which is actually on the Right Decision service, even though they call it RefHelp. The Dumfries and Galloway one is a Right Decision service resource. So we do now have quite a number of boards using the Right Decision service for their equivalent of RefHelp, if you like. So it's a growing area. These things do take time, to evolve and spread.
Okay, thank you. I hate to be the person to stop the conversation when there's a good discussion going on, so apologies. But moving on with the agenda this afternoon, one of the key things, I guess, about developing a network is about agreeing that common purpose. And the sort of current working definition, if you like, around the common purpose is to ensure sustained improvement in the quality of patient care and rehabilitation through collaborative working. So I guess one of the questions for you now to start thinking about within your breakout groups is this purpose the right one? Okay, so it's important in terms of setting up the network, and of course it will help us to define the structure and the governance model around the network. So we are going to invite you to move into breakout rooms, but before we move into the technology aspect of it, I've been asked just to remind you of a couple of ground rules for the breakout rooms. So first of all, because according to my numbers here, there are 67 of us in this call this afternoon. So we're asking people to introduce yourselves before you speak, please. Where possible, if you can, keep your camera on, unless, of course, you are experiencing transmission problems, because that clearly can occur. If you're not speaking, if you could mute your microphone, we've heard the consequences of not doing that, and you heard the aliens accompany me earlier on in the chat. Being respectful of others and others' views. You don't need to agree with them, but it's about being respectful that people will have different perspectives, and just making sure, it's probably more to the facilitators to make sure that everyone has the opportunity to speak. It's okay to raise single issues to illustrate the point that you want to make, but facilitators will need to keep you to discussions on the topic. And finally, because time is limited, we do encourage you to use the chat to record your point if you don't get the chance to speak. And it's fabulous seeing all the discussions that are coming through and all the questions and comments coming through the chat as the session progresses. So that's the rules, okay? I know you're all going to behave